Hi, this is Dr. Verheesen. We're going to go over week 6 now in community health. As far as the PowerPoint slides, you do have a slide deck on your Blackboard. It's going to be slightly different, but nothing that's consequential. It just means I added a couple of slides in order to illustrate points, but you can take notes on that. So I'm going to share my slides with you. While I do this, I just want to reiterate that you can always reach out to me if you have any questions going on, what's going on for the week. Okay, so you should be able to see my slide deck now. I'm going to open it up all the way for you. All right, here you go. This first slide is one that Izzy actually shared with us as data for her COVID update this week. And we are really one of the hot spots that's happening right now with COVID. So I'm sure you've heard about that on the news. But I also know they are really busy. And so maybe listening to the news isn't a priority. But there are actually some actions taking place this week with some of the teachers unions, of which your faculty are not members of those teachers unions. They're teachers unions for K through 12, but they are in starting to protest that they really want the schools shut down, and they're actually naming universities and colleges as well as shutting down. So we've been doing really good here from Concordia, but I know this is a really hot topic for people. So here in Ozaukee County, we've had a total of 1,329 cases since the beginning of COVID, of which we've had 19 deaths. We've talked about that before. Most of those happened within extended care facilities. And our last 2 reported cases, as of the data that Lizzie gave us on Monday, was on 9/24. We had 2 cases reported that day. So today we're going to talk about communicable diseases, prevention, and risk reduction. And prevention is a huge thing for public health. If you were going into graduate level work in public health, you'd be spending a great deal of time on this. We're going to cover it very briefly, but I will say, ding, 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 for NCLEX, that this is something that you should know. If there's anything you should know about community health, preparing for your licensing exam, it would be to understand the levels of prevention. So there are not a lot of questions typically on the exam regarding community health. That will probably be changing in the future, but for you, there will probably not be a lot of questions. But you should know the different levels of prevention. So let's cover that right now. So this is a triangle that's very common. You see triangles all the time in models, right? But it talks about, on that lower level, you can see there it says it targets social and economic policies affecting health. And we've been talking about that. We've been talking about that for the first 6 weeks here, the first 5 weeks. I guess we're in week 6. About what do we really target? What are we really passionate about in public health as far as wanting to change in policy and administration? And we talked about economic factors and about global health care. But those are primordial prevention. You don't hear too much about it because we usually call it economics and policy. We don't call it primordial prevention, but effectively that's what it is. Then primary prevention is one you hear about a lot. And really primary prevention has to do with patient education, vaccinations, seatbelt laws, those kind of things. How can we keep the public healthy? What do we identify as a risk, and then what can we do about it? A good example is lead poisoning in children when we used to have lead-based paint, or when we used to have gasoline that had a lot of lead in it, and then we realized that was causing a public health risk, and those things were mitigated. And so that's what primary prevention is. It really is, how do we keep a person from getting sick to begin with? What can we change in our neighborhoods to be able to do that? I'll have an example for you. Secondary prevention really talks about, once this person's either been exposed to the disease or possibly has the disease, how can we screen them to be able to give them the tools that they need to lead a healthy life? So a good example of this is STI testing, right? So STI screening, sexually transmitted infection screening, is recommended annually from any time from a person becomes sexually active until they're about 25 years old. And what that does then is say, you know what, you may not know that you've got this, but we'll do the screening test. And if you do, we can give you something to either cure it or mitigate the effects on you. So that's really about secondary prevention. Again, we'll look at one of those. Tertiary prevention is really about, we've identified that this population has this disease or illness or this condition or this risk factor out in the public, and then how do we help them live with that? How do we help to rehabilitate them? They might not get to a perfect state of health. We're really talking about getting them to a state of health that's good for them. But how can we do that? And again, I'll give you an example so that you can understand this. So let's move forward. So this is a program that I was intimately involved with when I worked as a nurse in the free women's health clinic, and it's called Back to Sleep. And it really looks at our safe sleep. It really looks at impacting sudden infant death syndrome. So let's go back 20 years ago, 30 years ago, 40 years ago, 50 years ago. And mothers were instructed to put their children to sleep on their stomach. And the reason that they were told to do that was because the thought back then was if a child would regurgitate some of its formula or breast milk, that if it was laying on its back, it could aspirate that, and that would be a health condition, right? So everybody put their babies to sleep on their tummies. That was just common practice. It was, you just always saw that. The other thing that you saw was if you loved your baby, then your crib was filled with stuffed animals and bumper pads and quilts, all sorts of things to be able to stimulate your baby visually, tactily, and to keep them safe. They thought, bumper pads is that pad that goes around, and you would use that in order to not have your baby's arms or legs fall out of the crib slots. And it was very common practice. And a well-equipped nursery would have these things in the crib. What they have found about sudden infant death syndrome is that they feel that what happens is that a child gets into a position, an infant, particularly when they can scoot. So let's say you put them on their tummy, they scoot their little knees up underneath them, and they wiggle those a little bit. They're not doing anything intentionally yet, usually, but they are just kind of wiggling. They get themselves like into a corner. They get themselves up against the bumper pad. They get themselves up against a pillow, perhaps, or a stuffed animal. And the CO2, the carbon dioxide that they're breathing out, now becomes concentrated in that little pocket of air that's around their face. And what happens is we have baroreceptors that, as adults, that we recognize that and we kind of take a deeper breath. We recognize we're not getting enough carbon dioxide. Well, they have baroreceptors as well, not as mature as we do, but they also lack the ability to move their head and to move their body to get in a position to get more air. And so they're feeling that some of these sudden infant death syndrome children were the result of them getting themselves in an area, breathing this in. Now they've overloaded on carbon dioxide. They stop breathing and they succumb to it. And tragically, there's been lots of people that have been convicted of child abuse because they had a child that died unexpectedly, and they only can suspect that maybe it was that somebody beat the child or mishandled shaken baby syndrome or something like that. So about 20 years ago, about 20 years ago now, they started this. It really hit its big effort for education about 10 years ago. They started this, what if we put our babies to sleep on their back? What if the risk of aspiration is not near as high as the risk of sudden infant death, of perhaps this breathing problem? And of course, with sudden infant death, nothing ever shows up on autopsy, so it's all hypothesis. But they decided that they would try this. So they started instructing moms to put their babies to sleep on their backs. And they also said, as you can see in this, in that one flyer there where the babies, all these babies are sleeping on cribs on their back without bumper pads. They only have probably a very fitted sheet. They might have a mattress pad underneath that, but that's about it. And you can, rather than put a blanket over them, you put what's called a sleep sack on them, which is the baby up in the upper left-hand corner is wearing a sleep sack that is just a zippered bunting type of thing, and it keeps them very warm. When they introduced this, what happened was dramatic. The amount of children dying from SIDS, or some sudden infant death syndrome, dropped by 50%. 50%. We still have children that die of SIDS. We still have unexplained infant death. But this was you would never kind of imagine that you would have those types of results on something that you were this is what our hypothesis is. It's been highly, highly successful. It still needs to get out to the general public, because what happens when you have a young mother is that auntie or mom or grandma is going to influence the mothering behaviors of that new mom. And so, auntie will say, well, we put all of our children to sleep on their tummy and none of them ever died of SIDS. We never had anybody die of SIDS, which is probably accurate, but it doesn't mean that it's the best practice. So this would be primary prevention. We are taking this population of infants who are at risk for dying of SIDS, doing an intervention, doing patient education to the moms, doing health promotion, getting the word out, and thus dramatically influencing the health outcomes of that population. Okay, let's look at a secondary one. So this one's secondary, both of these. Screens are secondary. I really like both of them. The one on the left I really like because it talks about, I had to look up ultrasound screening. I have to admit I didn't know what that was for a dental screening, and it really talks about they do that in order to quickly assess a tooth viability. So that would make sense if you're doing screening. But this is a dental screening on the left by University of Florida College of Dentistry. And they're saying they would do dental screening. It's always going to be, or most of the time it's going to be free of charge. That's the way you do screenings. They would do a dental screening. They would do blood pressures, HIV testing, and body mass index. And basically, you try to think, how many things can we offer the public to draw them in, right? The thing I like about the one on the right, which is by Vidant Hospital, and it says it's in Dublin. I don't know where Dublin is. But anyway, it says high blood pressure, high cholesterol, high blood sugar, not sure. Well, that's exactly what screening's about, right? People don't know they have these things, or they don't know how to manage them if they've ever been told about them. They just I feel fine. I mean, I've had high blood pressure for years and years and years and years when I was pregnant with my second daughter. It doesn't affect how I feel on a daily basis. And so I need to monitor that, right? And I need to medicate it. So both of these, this will be secondary prevention. People already have these things and we're screening to find them. And then tertiary, which is a little bit harder to understand, but it's like, how do they manage once we have diagnosed them? How can we help them in the public? How can public health nurses help them? This one is a healthy cooking workshop. Now, this one happens to be sponsored by a corporate sponsor, Whole Foods, which is a pretty common thing. You get sponsors so that you can have all the things that you need in order to do something like this. They probably supplied all the groceries. And this one happens to be, I think, vegan, but you could have all different ones. You could do a DASH diet for hypertension, right? That's the diet that really concentrates on lowering sodium and increasing magnesium and things like that that are good for blood pressure. So you could have a DASH diet. You could do anything like that. But this is a public health promotion so that people who have a certain risk condition within the population can learn about it. I know that we were doing one at Concordia, the occupational therapist, I think it was occupational therapy. We're putting out an advertisement saying, if you're over 60, come in, we'll do a free fall assessment for you. Well, that was good for the students, right? The students need to learn how to do fall assessments. But it was also good for me because maybe I don't know I'm at risk for falling. Maybe I don't do any of those maneuvers that I used to do, like, turn my head real suddenly. Maybe that does make me become unbalanced. I don't know. So learning how to screen for these, learning how to prevent them, screen for them, deal with them is really what these prevention measures are about. Now, I put this slide in here again to illustrate the processes that we go through. We have processes in place so we don't forget steps. And so the public health model on this particular one says define the process, identify the risks and the protective factors. So you want to decrease the risk, increase protective factors, right? If you're at risk for obesity, decrease the risk of fat foods and sweets, and increase the protective factors of fresh fruits and vegetables, right? So how do we do that if they don't have access to fresh fruits and vegetables? Develop and test your preventive strategies, and then assure widespread adoption. If, I will put a caveat there, if it's successful, you may need to go back and rethink what you were proposing might work. But if you get it with a population, you do your pilot study and you find out it's actually working, then you might adapt it to other people. This is part of what you're learning this week is on big data. And big data is really important now. It wasn't important, many years ago because we didn't have computers to be able to really grind this data down to a granular level, but we do now. And so just like when you were doing your global health projects, you were looking at big data there. And that's exactly what this is. So this is just an infographic depicting big data. But big data really helps us to break down information into chunks. And it can come from anywhere. It can come from medical records. It can come from different payer records, insurance records, things like that, where we can get big data and really look at that and decide what we need to concentrate on. Now, you saw a video, I'm sure you probably already have seen it, but if you aren't, you will see a video this week from Dr. Utton. And Dr. Utton it talks about chronic stress, right? And he looks at the narrative. And one thing he talks about is the narrative says these low-income populations are not entitled to a fair and robust social contract. So a social compact or social contract is the ability for us to say as a society, this is what we're going to do to help the other members of our society. An example of that would be secondhand smoke. We decided that smoking was not going to be allowed within restaurants, right? It started in certain cities and then it expanded, but that's because secondhand smoke. So I don't choose to smoke, but somebody across at another table may choose to smoke, but I would be negatively impacted. So the social contract says we are not going to do that because those people could be injured from that. One of the social contracts we have right now is the masking, right? We are doing that for other people. We're not doing it for ourselves. We're doing it for other people. So we talked about changing the odds for healthcare. And I don't know if you were surprised, but I was when I first saw this, that your zip code could be more important than your genetic code. And so when we look at that, we look at this implicit agreement among members of society, right? The social compact to be able to improve health. And what we've done is we have as a society, he says, let down the people in certain geographic locations that we don't feel, or it appears we don't feel, are as valuable as other people. And so what do we do as population health nurses or public health nurses to reduce the risk in this area? Well, first thing we do is identify it and call it out for what it is, whether or not it's increased crime within a geographic location, whether or not it is a lack of transportation, whether or not it is a particular area has a lot of human trafficking in that area, and then it's not safe. Just those things, call them out for what they are, and then go through that cycle and decide how we're going to combat it. And many times well, most of the time, we can't do it alone, right? We have to do it with other members in our community, including, police officers, social service workers, those types of things, to be able to get things working. And the people themselves, the community assets, the people that are the community coalitions are really important in this. So what we did in class and what you can do on your own is that you have that little worksheet to look at this, but I'm going to go over it now because I think you've probably at least taken a look at it. So if you open up on Blackboard, you'll see that there is a document in there that's called Life Expectancy in Wisconsin. It's all sorts of big data, right? All sorts of stuff. And what it's looking at is life expectancy, because we saw this video. We want to look at what the life expectancy here is in Wisconsin. And so really what I asked the class to do was to look at what do you come up with for the shortest and what do you come up with for the longest life expectancies according to that particular document. Okay, so they looked it up and lo and behold, they come up with the fact that Menominee has the shortest life expectancy at 72.5. And Kewaunee has the longest at 82.0, almost 10 years difference. And you can see on the map, they are not that far apart from each other. So then as a public health nurse, we ask the question, why? Why, if you live in Menominee County, do you live to an average age of 72 and a half, but travel a little bit to the east and you're not now in Kewaunee? Why is that at 82.0? There's a lot of factors that affect it, but we had a good discussion about that. I'll share some of those results. So here we have, over on the left, you will see a map of Wisconsin. And those yellow areas, I don't know if you can read it, but those yellow areas are reservations. We all know the history with Native Americans and how they were brought to these reservations and kind of sequestered there. And what has happened is there is rampant depression, alcoholism, sexual abuse, those kind of things that happen within reservations. And this happens to be one of the biggest, if not the biggest reservation in the state of Wisconsin. Well, that tells you a lot about the health risks of the Menominee people, because they have the shortest lifespan of anybody within Wisconsin. Travel a little bit to the east, and we're looking at Kewaunee, and let's look at what this is. It's a beautiful harbor resort area. Has some industry, but not really industry that pollutes. It doesn't have like a lot of paper mills or anything like that, or foundries that would pollute the air or the water. Has a lot of recreation. People are out being healthy. People move to that area for the recreation. And these people live a lot healthier lives, and their lives are on an average of 82 years. So these are the kind of things that we look at when we are public health nurses. We're really looking at this comparison and looking at what does this data tell us, and what can we do about it to make it better. So we might have programs in place then for the Menominee people to say, how can we bring healthcare to them? How can we make sure that they have resources to fight alcoholism? How can we bring behavioral health and mental health services to them? How are they accepted? Does it need to be somebody from within the Menominee people themselves, or can outside people come in and help with this? If outside people come in and help with it, do they need access somehow? Do they need approval from someone? We talk about all of these things. I know when I worked as a sexual assault nurse in Madison, we had a lot of ho-chunk in that area. But we didn't see a lot of ho-chunk at the hospital, because coming in for sexual assault services was not something that was well accepted within that tribe. On the whole, we're making these generalizations because that's what we're doing, public health. We're really looking at the big picture. It doesn't mean each individual person within that population behaves that way or thinks the same way. Okay. All right, and then we went over the case study. I'm just going to go over it really quickly for you so that you can understand really what this was. So we had the matching of the terminology, and I'll just give you the answers for that. I'll give you a moment to kind of pull yours up so you can look at the answers for the case study. And I'm going to take my slide down while you're doing that. So what I'm talking about is the sheet that was critical care activity epidemiology. We had it from last week, and I said I would give you an extra week to finish it because I think some of the things we talked about this week are really important for that. So if we're looking at the top part, the matching part, the ability of an infectious agent to survive in adverse conditions is F, which is resistance. Number 2, ability of an infectious agent to produce toxins that are harmful to the human body is H, or toxigenicity. Sorry, I can't pronounce that very well. Number 3, primary cause of a health-related problem is A, an agent. Number 4, a living intermediary that carries an agent from a reservoir that should be from to a susceptible host is C, a vector. So insect could be a vector, an animal could be a vector. 5, client system affected by the particular condition under investigation is B, the host. So that's the person that's actually affected by the particular condition. 6E is, 6 is E, and it's the ability of an infectious agent to enter, survive, and reproduce within and cause disease in another individual host. And so that really talks about how you can infect that host, right? 7, severity of health problems caused by an agent or the proportion of people with the disease that develop serious illness or die is G, virulence. So how virulent is that? That's what it's talking about. And 8, ability of an agent to cause a disease when a susceptible person is exposed to the infected agent, and that is D, pathogenicity. All right, so let's go on. The first question talks about in the case study, I'm not going to read the whole case study to you. Sending the more severely affected children home meets which of the following public health actions and interventions warranted when there is a suspected outbreak. So it's not A, it's really too late for any prophylactic antibiotics or anything like that. I mean, kids are already infected, so that doesn't work. Prophylactic is supposed to work ahead of it as a primary prevention mechanism. B, education. Nope, we want to do that in the future to prevent this from happening again, but that's too late now. So it's C, prevention and control. We want to look really at our prevention triangle and look at how we can control this. And then D, early identification of problems. No, we're past that point. Okay, the second question on the first question on the second page. To determine if an outbreak exists, which of the following factors must be considered? And it's actually all of them. We want to look, is this common for this area? If not, it might be an outbreak. Is there an increased number of cases for the time, place, and the population? Or is it more severe presentation? So are we having more people with it, or the people that are presenting with it are more severely ill? So it's really all of those. The next question, what is descriptive epidemiology and what is line listing? Descriptive epidemiology really talks about describing the person, place, and time of the onset of symptoms and the signs and the symptoms. So it really is a kind of a narrative, right? So Susie, who came into the office, got sick. She said she got sick Tuesday morning, but her mom still sent her to school. She started vomiting at a certain time, you know, those types of things. I mean, kids aren't real good historians, but the school nurse was there. So that can be a descriptive epidemiology. Line listing is really a timeline. Let's look when everybody started presenting. We could do the nurse's office, we could do when their symptoms started or whatever, but we're doing a line listing to be able to kind of go back to, can we identify a patient zero in our school? And can we kind of get some clues from that? Because we're trying to figure out this big puzzle, right? Okay, next page. Which of the following are control prevention measures, and select all that apply? I'm just going to read them to you. So A, removing an ill food handler would be a preventive measure. B, recalling contaminated food products. Not C, analyzing the incident retrospectively is not prevention. That makes sense. D, yes, closing a restaurant or a manufacturing plant. You might not even know where the contamination is coming from, but you're going to close down that plant until you figure it out because you know that's the source of where it's coming from. E, implementing new protective policies. That really isn't control prevention. That's further on, we want to put in new policies, but right now, what are we going to do to control this? So not E. F, cleaning contamination, absolutely. And G, providing prophylaxis to exposed population. So that really means about if we had an entire group that was exposed to salmonella, and we know that they were, can we give them medication to keep them from getting sick? All right. The next question, after determining the source of the contamination was tomatoes, what should Emily and the surveillance team have done next? They really should have looked at what was the source, how can they interrupt the transmission of that source, and how can they disrupt the natural history of the disease or the natural progression of how that disease happens. In other words, they could do a tomato recall. They could get the products off the store shelves. You've all seen those on the news. They could alert the public not to eat tomatoes, so it could go on the news at night, right? And things like that. All right. Last one. Re-examining the hypothesis, re-interview. Oh, wait, sorry. It was giving you the answer. Emily says, Sarah, we did a large number of interviews that led to the hypothesis that it was in the tomatoes. So we did a tomato alert. People stopped eating tomatoes, but the incidence of salmonella did not decrease. What do you think we should do next? Well, the next thing is that they would re-interview people, or they would look at their clues, just like you see on a detective show. They look at the clues and decide what they've missed. And what they missed in this situation was that people who ate the tomatoes also ate jalapenos, and that was actually the source of the contamination for salmonella. So they do the best they can, they make the best guess, and they decide how to move forward with that. Okay, that's it for today. I told the group on Monday that I am going to be sending out an email. I hope to do it by the end of tomorrow, which is Friday. I don't know if I'll get to it, but soon, to talk about whether or not students want to be in class after Thanksgiving. Traditionally, we don't have class until 4 o'clock on the day after Thanksgiving weekend for people to kind of travel, but we will have full class on the Monday. So it gives us an extra day of class. I need to decide what I want to do with that. So I will be sending out just an email survey to see if people want to attend face-to-face after Thanksgiving, and I'll accommodate however you guys decide. Okay. All right. Have a good week. I hope everything's fine, but if not, please reach out to me and let me know, and we can work on anything. Okay.